Hello everyone, my name is Daisy. I am an ophthalmic technician at Indira Gandhi Government General Hospital and Postgraduate Institute, Puducherry. I am currently pursuing a diploma in strabismus management at the Indian Academy of Optometry. I will be discussing the clinical assessment of strabismus based on deviation, comitancy, corneal reflex and cover test. Strabismus is one of the most common ocular disorder encountered in pediatric and neuro-ophthalmology practice. Proper clinical evaluation helps us determine the type of deviation, identify the underlying cause, assess binocular function and formulate an appropriate management. Strabismus is a misalignment of the visual axis of two eyes such that both eyes are not directed toward the same fixation target simultaneously. The deviation may be constant, intermittent, unilateral or alternating, manifest or latent. Clinical assessment begins by identifying the nature and characteristics of the deviation. Uniocular movement examination or duction testing evaluate the function of individual extraocular muscles by testing each eye separately. It is essential for identifying the muscle palsies, nerve palsy, identify mechanical restriction to gauge overaction and underaction of muscles, diagnose incomitant strabismus, plan appropriate treatment or surgery. Version or binocular conjugate eye movement in which both eyes move together in the same direction. Version testing allows us to detect muscle underaction or overaction, identify yoke muscle abnormalities, evaluate diplopia pattern and plan surgical treatment. Vergent movements are disconjugate movements where the eye move in opposite direction. These movements maintain binocular single vision during changes in fixation distance. Vergent testing is important in diagnosing convergent insufficiency, divergence abnormalities, and assessing functional vergence results. You notice the quality of ocular tracking. Saccades are rapid eye movements from one target to another, while the smooth pursuit allows continuous tracking of a movement target. We also look for nystagmus, which consists of involuntary rhythmic eye movements. Abnormal finding may indicate cranial nerve, cerebellar, vestibular, and supranuclear pathology. Strabismus can be identified according to the direction of deviation. Esotropia refers to inward deviation, exotropia to outward deviation, hypertropia to upward deviation, hypotropia to downward deviation, and cyclotropia to torsional deviation. A detailed history is crucial. Important points include age of onset, sudden or gradual appearance, intermittent or constant nature of the deviation, presence of diplopia, trauma, neurological symptoms, family history, previous treatment, and abnormal head posture. External examination should be include assessment of facial symmetry, ptosis, proptosis, epicanthal folds, orbital asymmetry, lid abnormalities, and the head posture. These findings may provide due to the underlying cause of strabismus. Patients often adopt an abnormal head posture to maintain binocular single vision and minimize diplopia. A face turn commonly indicates horizontal muscle palsy. Head tilt suggests cyclovertical muscle involvement, and the chin elevation or depression usually indicates vertical deviation. Esotropia is characterized by inward deviation of one or both eyes. Patient may develop cross-fixation, amblyopia, or diplopia in acquired cases. A comprehensive clinical assessment of esotropia includes history, visual acuity, refraction, alignment testing, ocular motility evaluation, sensory assessment, and neurological examination. Careful evaluation allows accurate classification of esotropia and guides appropriate optical, orthoptic, medical, and surgical management. Exotropia is an outer deviation of the eye. It is frequently intermittent during the early stage and becomes more evident during fatigue, illness, or inattention. Assessment include measurement of distance and near deviation, sensory evaluation, zero acuity testing, and control assessment. Intermittent exotropia is most common form of exotropia. It is typically begins in the early childhood and may progressively worsen. A characteristic clinical feature is closure of one eye in bright sunlight. Suppression occurs only when the eye deviates, and amblyopia is relatively uncommon. Convergent insufficiency is a common binocular vision disorder characterized by a greater exophoria at near, receded near point of convergence, and reduced positive fusional vergence. Patients typically present with symptoms during near work. The vision therapy remains the mainstay of treatment. Hypertropia and hypotropia are vertical form of strabismus in which one eye is positioned higher or lower than the fellow eye. Superior oblique palsy is the most common cause of acquired hypertropia, while restrictive disorders such as thyroid eye disease commonly produce hypotropia. Three-step test, Parks-Biskowski test, used mainly for superior oblique palsy. First step, identify the hypertropic eye. Second step is to determine the increase in right or left gaze. Third step is to determine the increase with head tilt. It interprets localized paratic cyclovertical muscle. Cyclodeviation is a torsional misalignment of the eyes resulting from abnormal rotation around the visual axis. Patients commonly present with torsional diplopia and compensatory head tilt. The double Maddox rod test is the gold standard subjective test for measuring cyclodeviation, while superior oblique palsy remains the most common clinical cause. The position of the fovea relative to the marker of detecting ocular torsion is in cyclodeviation. Clinical assessment of strabismus based on comitancy involves careful measurement of deviation in multiple gaze positions, evaluation of ocular motility, sensory status, and head posture. Determining whether a deviation is comitant or incomitant is essential for identifying the underlying cause and selecting the most appropriate management strategy. Comitant strabismus is a form of ocular misalignment in which the angle of deviation remains constant in all positions of gaze. There is no limitation of extraocular muscle movement. The video demonstrates comitant strabismus. Notice the angle of deviation remains relatively constant in all directions of gaze, and ocular movement are full. The pattern is typical of childhood strabismus such as accommodative esotropia or basic exotropia. Unlike comitant strabismus, where the angle of deviation remains the same in all directions of gaze, incomitant strabismus is characterized by the deviation that varies depending on the direction of gaze. The variation occurs because one or more extraocular muscles are weak, paralyzed, overacting, or mechanically restricted. This video demonstrates incomitant strabismus. The deviation changes with gaze direction, and there may be the limitation of ocular movement. Here the first video shows right restricted adduction with left abducted nystagmus. It may be case of internuclear ophthalmoplegia, and the second one is complete third nerve paralysis with internal ophthalmoplegia. Look at the right eye is dilated and drifted outside or downward. A comitant strabismus, the deviation remains equal in all gaze position and ocular motility is full. It commonly present in childhood and diplopia is uncommon. The slide compares version and ductions. Versions assess binocular eye movements, whereas duction assess each eye individually. By comparing the two examinations, we can distinguish true muscle weakness and binocular adaptation or suppression. The 9 cardinal gaze examination provide dynamic information about ocular motility that cannot be obtained from the static alignment measurement alone. It is fundamental for diagnostic incomitant strabismus and localizing the affected muscles or cranial nerve. The 9 cardinal position of gaze evaluate the function of all extraocular muscles in the field of action. This examination is essential for detecting muscle paralysis, overaction, restriction, and incomitant strabismus. This video demonstrates primary and secondary deviation. When the normal eye fixes, the deviation measured in the primary deviation is the primary deviation. When the paralytic eye fixes, the deviation is the secondary deviation. In paralytic strabismus, secondary deviation is greater than the primary deviation due to Hering's law of equal innervation. Corneal reflex tests are fundamental tool in the clinical assessment of strabismus. The Hirschberg, Krimsky, the Bruckner tests provide objective information about ocular alignment and are particularly useful in young children and uncooperative patients. Symmetry of corneal light reflex indicates normal ocular alignment, whereas displacement of reflex helps identify the presence, direction, and approximate magnitude of strabismus. Hirschberg test is often the first alignment test performed during the strabismus examination. It helps identify the presence of approximate magnitude of a deviation and guides further evaluation using cover test and prism measurement. This Hirschberg corneal reflex test is a rapid objective measurement of assessing ocular alignment. By observing the position of the corneal light reflex, clinicians can detect and estimate the magnitude of strabismus, especially in children and uncooperative patients. The amount of corneal reflex displacement can be used to estimate the angle of deviation. Reflex position of approximate deviation pupil margin 15 degree is approximately 30 prism diopter. Midway between center and limbus is 30-degree deviation, which is approximately 60 prism diopter. At limbus, the deviation is 45 degree, which is approximately 90 prism diopter. Beyond the limbus, that is more than 60 degree of deviation is approximately more than 120 prism diopter. As useful clinical rule is 1 millimeter displacement is 7 degree of deviation, which is 15 or 14 prism diopters. Angle kappa an important concept in the evaluation of strabismus because an abnormal angle kappa can simulate a squint even when ocular alignment is normal. Angle kappa is defined as the angle between the visual axis and the pupillary axis. The visual axis is the line joining the fixation point to the fovea through the nodal point of the eye. The pupillary axis is an imaginary line perpendicular to the cornea that passes through the center of the pupil. Normally, the fovea is located slightly temporal to the posterior pole of the eye. Because of the anatomical arrangement, the corneal light reflex appears slightly nearer to the center of the pupil. This creates a positive angle kappa, which is normal physiological finding. A large positive angle kappa may create the appearance of the outward deviation known as pseudo-exotropia, whereas a negative angle kappa may create the appearance of pseudo-esotropia. This video demonstrates the Krimsky test. Prisms are introduced until the corneal reflex becomes symmetrical in both eyes. This provides an objective estimate of the angle of deviation and is particularly useful in infants and poorly cooperative patients. Bruker test is an excellent screening tool that compares of red reflex of both eyes simultaneously. A bright reflex is often seen in the deviating eye, and asymmetry of the reflex may indicate strabismus, anisotropia, or media opacity. Cover testing is the cornerstone of clinical assessment in strabismus. The cover-uncover test identifies tropias, and the alternate cover test reveals the total deviation, and the prism alternate cover test accurately measures the angle of misalignment. Careful interpretation of cover test finding is essential for diagnosis, classification, and management of strabismus. In this video, the cover and uncover test is performed. Observe the uncovered eye while the fellow eye is covered. Any refixation movement indicates the manifest deviation of tropia. The direction of movement identifies whether the deviation is ESO, EXO, hyper or hypotropia. The video demonstrates the alternate cover test. The cover is moved rapidly between the eyes, complete disrupting fusion. The recovery movement seen when the fixation is regained indicates the total deviation, including both tropia and phoria. Here the video shows the right eye is hypertropia while occluding in the right eye, and the left eye shows hypotropia. The principle of the prism bar cover test is based on the neutralizing the refixation movement seen during the alternate cover test. Prisms are introduced before one eye and the prism strength is gradually increased until no movement is observed when the cover is alternated between the eyes. At this point, the deviation is said to be neutralized and the prism and the at this point the deviation is said to be neutralized and the prism value represents the angle of deviation. The direction of the based depends prism base depends on the type of deviation being measured. For esotropia, base out prism is used because it moves the image towards the apex and neutralizes the inward deviation. For exotropia, a base in prism is used to neutralize the outward deviation. For hypertropia, a base down prism is placed before the hypertropic eye. For hypotropia, a base up prism is used. Tropia is a manifest deviation present even when both eyes are open, whereas phoria is a latent deviation that becomes apparent only when fusion is disrupted. The Maddox test is with simultaneous prism neutralization is a simple and effective method of measuring phorias. An A pattern is diagnosed when the horizontal deviation differs by at least 10 prism diopters between up gaze and down gaze, whereas V pattern requires a difference at least 15 prism diopters. Superior oblique overaction commonly causes A pattern, with while inferior oblique overaction commonly causes V patterns. The video demonstrates diplopia assessment. Patients with incomitant strabismus typically experience diplopia that worsen in the direction of action of the affected muscle. Diplopia charting helps localize the paratic muscle. This video illustrates health chart interpretation. The smaller field corresponds to the affected eye and indicates the weak muscle. The larger field demonstrates the secondary overaction of the contralateral synergist. Health chart is useful for diagnosing, monitoring progression and surgical planning. Forced action test differentiates paralytic from restrictive strabismus. A positive test suggests mechanical restriction, whereas a negative test suggests muscle paralysis. Sensory evaluation assesses how the prism processes visual input from both eyes. We evaluate fusion, suppression, stereopsis, and retinal correspondence using tests such as Worth-Fodor test, Bagolini glass, Simon-4, stereo acuity test, and the 4 prism base out test. Thank you.